and uh, video. So Dr. Sanjay Dar would like to just make a small comment.
Thank you. I invite all of you to the next Wiroc. It's a privilege and honor to be part of BOS. And as a president-elect, I wish you all a good new year. And I hope to see you all. We have tried to get the rates down to the bare minimum. And it takes a lot of hard work. And I hope to see you all. You have the window of opportunity till 5th January to register for the lowest ever rates for Wiroc. Thank you very much.
Thank you very much, sir. And I'm pretty certain that all of us are looking forward to the next Wiroc. Having said that, we are not yet over because we come to the most interesting session, which is the Young Surgeons Forum, a scientific paper presented by a young surgeon, a young member of the Bombay Orthopaedic Society. And may I now invite the two chairpersons for the session, Dr. Sudhir, Warrior, and Dr. Sunil Shahane, to start the session.
Good afternoon, and for the Young Surgeons Forum, I invite Dr. Mandar Agashe to do his presentation. Dr. Mandar, please.
Thank you, respected chairpersons, seniors in the audience, and my dear friends. It's indeed a great privilege and honor to me to present in this Young Surgeons Forum at the Wiroc Max 2022, and especially in this magnificent arena of the Geo World Center. I'll be presenting my work on modified Dunn Osteotomy, done for the moderate and severe slipped capital femoral epiphysis, my work over the last almost 10 years. But before I go further, it will be amiss if I don't acknowledge a few of my teachers and seniors who have helped me over the years. First and foremost, I would like to acknowledge my two mentors at the Rady Children's Hospital, where I did my pediatric hip fellowship in 2012, Dr. Dennis Wenger and Dr. Harish Osarkar. They really started me on my journey of pediatric hip surgeries. Dr. Prasad Gaurineni, who is a hip surgeon from Chicago, he used to come to Mumbai to operate for pediatric and adolescent hips, and he gave me a lot of intraoperative tips on how to manage these difficult cases. My very good friend, Dr. Sandeep Vaidya from Thane, he used to help me in many of my earlier surgeries, and it was a great help when he was on the other side of the table, and he used to give me a lot of help during the surgeries. Dr. Venkat Das, who is the chief of pediatric orthopedics at the Ganga Hospital, was the previous fellow before me at the Rady Children's Hospital. And he and I started our journey in pediatric hip surgery together. So he gave me a lot of tips of how to start a pediatric hip practice, and those have really helped me over the years. Last but not the least, Dr. Sandeep Patwardhan has been a great teacher to me since many, many years. He has been one of my harshest critics with his typical Puneri comments. And in fact, he has taught me a lot of times about when not to perform this surgery, and those have also helped me over the years. I would also like to acknowledge these surgeons who have allowed me to operate on their patients, especially when I was starting off. So those are the real help of my cases here. Well, slipped capital femoral epiphysis, as we know, is one of the commonest adolescent hip disorders, which predisposes to early avascular necrosis and early hip arthritis, seen more often in overweight adolescent boys, and has a wide spectrum of presentations and a lot of controversial treatment modalities. These treatment modalities range from a simple, minimally invasive in situ pinning to a big, morbid procedure, which is a modified Dunn procedure. Traditionally, we have been taught that slipped capital femoral epiphysis means in situ pinning. The genesis of this was one of this long-term paper, which was from the Ponseti group, which showed results which were quite good, but especially for mild to moderate slip. This was a mild to moderate slip, which was X-ray from their article. This is a 38-year follow-up, which shows an apparent clinical good result, but as you can see, he has a very big cam. The evolution of open procedure started with these articles by Professor Dunn and Fish in the early 60s and then 70s. They described a cuneiform osteotomy done from the anterior approach for a moderate to severe slipped capital femoral epiphysis. They showed good early results, but these were not replicated by other authors with an avian rate of an unacceptable 40 to 60%. The Renaissance started at this place, which is Bern in Switzerland, by this Renaissance man, Professor Reinhold Ganz, who really ushered in the era of the present hip preservation. One of the first major articles of his was the anatomy of the medial circumflex femoral artery, and those really changed our perspective about the proximal femoral anatomy. He then put forth his landmark paper on the surgical dislocation, which is basically a versatile procedure which is capable of treating a wide variety of intra-articular conditions in a safe manner by utilizing the knowledge of the branches of the medial circumflex femoral artery with the trochanteric flip osteotomy and the extensile retinacular flap formation being its two main steps. He then used this same surgical dislocation approach for moderate to severe slips to put forth his first article on modified Dunn osteotomy through the safe surgical dislocation approach in 2009. And I was lucky to start my fellowship just a couple of years later after the first publication of this modified Dunn procedure. So, in this study, what I aimed to analyze was to analyze the results of this procedure for moderate and severe slipped capital femoral epiphysis in terms of radiological parameters of slip angle and alpha angle, clinical parameters of hip range of motion and Harris hip score, and complications. This was an analysis of moderate to severe slips operated between 2013 to 2021. All of them were done by me, the single surgeon, and all cases were classified according to the Southwick classification, stability, and the chronicity classification, which is what we know. Clinical examination was done in the form of range of motion and Harris hip score, taken in a prescribed formula, especially in cases of stable slips, which could be examined. X-rays were done in all patients, and a CT scan was done in all cases. As we know, slips are associated with endocrinological issues, which were investigated and treated appropriately as required. The operative technique was that described by Zibart et al. In their article in 2009. The child is in a lateral position. A characteristic feature is this sterile sheet bag, which holds the leg when we are dislocating anteriorly. I'll be describing it in a few minutes. The incision is a standard lateral incision with a slight curve anteriorly, which is centered on the tip of the greater trochanter, about 10 to 15 centimeters proximal and distal to the greater trochanter. The facial incision mirrors the skin incision, which is curving slightly anteriorly. Once you go deep, what you can see is the two main muscles, the vastus lateralis and the gluteus medius, which meet in between at the greater trochanter into what we know as the digastric flap. This is where the trochanteric osteotomy is going to be, which is right from the base of the vastus lateralis to the tip of the trochanter. Initially done with a saw and later on completed with an osteotome, after which this trochanter with the digastric flap is retracted anteriorly so as to expose the hip capsule anteriorly. Once you do that, we have to do a capsulotomy, which is a Z-shaped capsulotomy, and thus you see the proximal femoral metaphysis and the epiphysis, which is slipped posteriorly. Dislocation is then performed anteriorly with the help of external rotation of the limb and a bone hook which goes over the femoral neck. This is then pulled anteriorly so as to expose the ligamentum teres, which is then made taut and then cut with a strong Mayo's scissor. This then completes the anterior dislocation, at which time the leg is put in the sterile sheet bag, which I described a few minutes back. The retinacular flap is then exposed. This retinacular flap is what contains the proximal femoral blood supply, which is on the medial and the lateral side. This is then cut anteriorly with a sharp blade and retracted so as to keep it completely attached to the proximal femoral epiphysis. A cleavage plane is created in between the metaphysis and the epiphysis. Again, a small osteotome is then placed so that the femoral head is gently levered in position, like so. Thus, this will create a full reduction of the epiphysis without damaging the blood supply. Fixation is then performed retrogradely with two thick wires, of which one of them is shifted to a 6.5 mm cannulated cancellous screw. The wire is then removed. The other wire is then withdrawn till the subchondral bone, cut and bent. The retinacular flap is then loosely closed with one or two approximating sutures. At this time, it is important to note whether the head is vascular or not. This is when we usually drill a small K wire, a 1.5 mm K wire in the proximal femur. You can see that there is this pulsatile bleeding, which is very, very important. It should not be just a ooze, it has to be a pulsatile bleeding. This shows that the proximal femur is still very vascular and we have saved it. After which the femoral head is reduced in the acetabulum by gentle traction, and then the trochanteric fragment is relocated and fixed with 3.5 mm cortical screws, and the closure is done in the routine manner. Postoperatively, an abduction pillow is given with restricted hip abduction for about 4 weeks, and the child is kept non-weight bearing for about 6 weeks till confirmation of healing of the trochanteric osteotomy. X-rays follow-up is routine, which is 6 weekly for the first 3 months, and 3 monthly and 6 monthly later on. X-rays are done at every visit, and a clinical assessment is done at every visit. This was a retrospective series of 35 patients with a mean age of about 13 years and a mean follow-up of about 2 years with a maximum follow-up of 5 years. This was done not just in Mumbai, but in 9 cities of the country, ranging from Indore in the north and Kanyakumari and Nagarcoil in the south. Most of them were males as expected, and about 2/3 of them were stable slips, and about 2/3 were chronic slips. An interesting feature about this series was there was a big time between the onset of symptoms and the actual surgery, which was almost 1 month, which is not very much seen in Western population. In Western series, the time between the onset of symptoms and the surgery was much shorter. About 2/3 of them were moderate slips with a mean slip angle of about 55 degrees, which significantly changed to postoperatively about 10 degrees. The alpha angle, which is an angle between the line down the femoral axis and a line drawn to a location where the femoral head becomes out of round, that is at a tangent, which is normal about 30 to 50 degrees. It normalized in our cases to about 45 degrees with a range of 30 to 60 degrees. The hip range of motion also came as close to normal as possible with a mean abduction of 35 and internal rotation of about 20 and a mean flexion of about 100 degrees. The Harris hip score was good to excellent in about 90% of the cases, with a mean post-op Harris hip score of about 80. This is a clinical case example of a 13-year-old male with a right-sided chronic severe stable slip. As you can see, there is a very, very high slip angle which was confirmed on the CT to be about 70 degrees. This is 4 years post-surgery, showing an excellent healing, no changes of avascular necrosis, the slip angle of about 5 degrees, and an alpha angle of 30 degrees. And this is the same child. As you can see, he is a big obese adolescent. You can't even make out which side he is operated for. He is doing all his activities. He wants to be a basketball player, which I am trying to prevent him from doing. And he is walking almost completely without a limp. Another child, which was an interesting case, this was done at Nagarcoil, which is a bilateral, unstable, acute on chronic, severe slip. Now, it's a very rare thing to have bilateral, severe, unstable slips. So, this was one of them. This was proved on CT scan. This is the early post-operative X-ray showing good healing, and this is at 5 years follow-up. You can see that the alpha angle is corrected very well, and this is him. I'm sorry, this video is not working. This is him at 5 years follow-up. He is now a first-year medical student and doing all his activities of daily living. We had a few complications. 2 of them were avascular necrosis. 1 was subluxation. This was a case of subluxation. This was a 12-year-old boy who had a chronic, stable, moderate slip. Intraoperatively, everything went off perfectly. I was quite happy with my surgery, but post-operatively, as you can see, that there is a subluxed hip. We re-explored, and what was found was there was an interposed capsule inside the acetabulum. This, once it was popped out, the hip went in quite well, and this is 12 months post-op, showing a well-reduced hip and no AVN. And this is 3 years post-op, again showing an excellent healing. Thankfully, no AVN changes. Sorry, this video is not working, but he is walking with a mild lurch, but otherwise doing all his activities of living. Avascular necrosis is something which is known and which does happen. We had avascular necrosis in 2 of our slips. Both were unstables, but no bleeding was seen at the time of dislocation as well as after reduction and fixation. As of now, that AVN is being treated conservatively. This study does have limitations. This is a retrospective study with a medium-term follow-up. I would like to follow this cohort up to a long term to see how it behaves. And unfortunately, we did not have a control group. This study is comparable to other international studies. This is one of the first from the Indian population and gives a good correlation of clinico-radiological parameters with a fairly low complication rate. As you can see, the numbers are comparable. In fact, ours is one of the higher end of the numbers. The AVN rate ranged from 4% to almost 50% in this series. In our series, it was 6.6%, which was on the lower side of the range. Hip instability and subluxation is a known thing. This was described by Upasni et al. A few years back. What he said was this may be due to capsular laxity, abductor weakness, or an extreme external rotation contracture which is seen in many of the kids preoperatively. Fortunately, in our case, the cause was an interposed capsule in the acetabulum, which was removed and thus which was treatable, and the stability was achieved. So what were the lessons learned in these cases? From me being a fresh-faced post-MS fellow in pediatric orthopedics at the B.J. Warrier Hospital in 2010, to me being a not-so-young presenter in the Young Surgeons Forum in Wiroc Max 2022. Keep adequate time for the case. This is a long, arduous surgery with a lot of technical details. Don't do many surgeries at that time. Keep it as a first case in the morning. Have a good assistance. Do it at a place which you trust. That is why I am extremely thankful to Sandeep Vaidya for being with me for many, many cases. A good consent and detailed explanation has to be given to the patients. There is a good chance of avascular necrosis, good chance of chondrolysis, good chance of stiffness, good chance of FAI. So all these things have to be explained to the relatives and the patient well. Here we have to explain to the patient also because he is usually an adolescent who understands many things. And develop specific instruments and keep them ready and available. A couple of them which I have developed is, all of my fellows know about these bone hooks. So I have 3 different sizes of bone hooks. I have developed, which go around the femoral neck of various sizes of the femur. And I have asked the implant guy to bend the long episiotomy scissor. Now this is very important because the femoral neck, the femoral head is completely posterior, and it is very difficult to reach the ligamentum teres to cut it. So this is a long, thick episiotomy scissor which I have asked to bend, and it's sharp at the tip. So this helps in cutting the ligamentum teres, especially in a very, very severe slip. Thus, to conclude, this is a safe, effective procedure, but only when performed correctly with a good amount of technical expertise. The unique feature of this series was a long duration of time between the onset of symptoms and the surgery, which thankfully did not affect the outcome. Low complication rate and extremely accurate correction can be obtained provided all technical details are fulfilled. And thus, we could publish this article in 2020, which was the first at that time and currently the largest series from the Indian population. Thank you very much.
Thank you very much, Mandar. Wonderful study, long-term, very patient, and beautifully put across.
Thank you so much, sir.
As always.
Thank you so much.
We do have about 6 minutes, so if there are any questions, yes, please.
Dr. Chinoy from Mumbai. Mandar, how do you find the plane of cleavage? And I noticed you didn't do any neck shortening. So how do you reduce it without the tension? Yeah. These two are important things.
So sometimes it is easier to have an acute or unstable slip where the cleavage plane is very easy to obtain. In case of a healed slip, then we do have to do a bit of femoral neck shortening. And what we do is that is why it is known as a modified Dunn procedure. There is going to be some form of cuneiform cut in the femoral neck, which will help me to reduce it. So in that case, it is very difficult to find a cleavage plane. That is why to do a modified Dunn osteotomy in a chronic healed slip is an extremely difficult thing. So we have to find it. So usually there is a color change between the proximal femoral epiphysis and the metaphysis, and that is where I start off. And usually once we go perpendicular to the direction of the epiphysis, that is where I get the plane.
Dr. Tiwari from here.
Yes, sir.
You said after fixation there is a pulsatile bleeding.
Right, sir.
Any case you got, there wasn't bleeding, and what you did?
So as I said, in the two cases where I did not get a pulsatile bleeding, so sometimes we can do certain things in order to bring that bleeding. So what I feel, sometimes when I feel that my retinacular flap dissection has not been good, or if I can shorten the femoral neck slightly more and relieve the tension of the retinacular flap. So these are the things which I can do in order to achieve a good bleeding. In some cases, whatever you do, the bleeding doesn't come. In which case, we just have to say this is the most that we can do, reduce it and hope for the best. I do give zoledronate. I have started giving zoledronate after about 3 weeks of the surgery, but I still don't know whether that works or not.
Mandar, just as a follow-up.
Yes, sir.
So the two cases where there was no bleeding, were they the ones who went on to get AVN?
Yes, sir. So that's what I have said.
So at the time of fixation, how you assess antiversion? Was there any your precise eyeballing or anything?
So finally
else?
It lands up with eyeballing, but what I started with is that there is usually an offset between the metaphysis and the anterior edge of the femoral head. So that should be about 3 to 4 millimeters. So that usually corresponds to a good amount of antiversion.
Dr. Bukhi, please.
Yes, sir.
Excellent. I just want your opinion on 3 points.
Right, sir.
One is that when you do the periosteal stripping, you do it in the center or lower down. Second is, before dislocation, if you cut the ligamentum teres first, then it will never cause subluxation. Because it's very difficult to dislocate with ligament teres intact. That is my point. And third is, what did you do for the opposite hip and the hormonal studies?
Okay. So let's start with the first. So I always cut it at the center because the proximal femoral blood supply comes on the medial side and the lateral side. Medially, the medial side is about 25%, the lateral side is about 75%. So I don't want to go near these two blood vessels. So it has to be right at the center so I get a good flap.
Okay.
Secondly, it is not possible for anyone to cut the ligamentum teres before dislocation.
Okay.
You have to subluxate the hip a bit. Only then will the ligamentum teres be visible. Because here the femoral head is completely posterior and inferior. The ligamentum teres is even posterior to that. So it's not possible for us to see the ligamentum teres at all unless we actually subluxate the hip.
Right.
Right? The third thing is that opposite hip, the contralateral hip screw fixation.
Yeah, 20% go in for the
Yes. So in Western population, there is a lot of teaching about doing a contralateral hip pinning. I have not had any patient where I have done a prophylactic contralateral pinning because in India, if we say that 80% chance hai ki nahi hoga, so they will take that 80% chance rather than 10 to 15% chance of wo hoga. So I just tell them, so especially if there is a very severe case on one side, and if I tell them that if there is even a semblance of hip pain on the other side you come back, they will usually come back when it's a mild slip and not wait for it to become an unstable or a severe slip.
Thank you.
Thank you, Mandar, for a wonderful presentation.
Thank you so much.
My only request to you would be, please do follow these patients up so that the next time maybe you can present your results in the Veteran Surgeons Forum.